So today I'm doing GI topic review. The structure of the day is like a 20-minute board review style questions, which I would like your participation in. And I have prizes to get you guys to participate. And they're definitely really planned out and not just things I found in my apartment.
Someone else.
Yeah. So we're gonna do 10 questions. And then the answers and stuff are pretty brief, but later we can talk more about topics. So we'll get started. So the first question, 2-year-old male refusing to eat for 2 days. Mom notes intermittent gagging and crying, but no vomiting. Heart rate 130, blood pressure 90/60, respiratory rate 30, 98.6 degrees Fahrenheit. He's well appearing, no pharyngeal signs of erythema, edema, or exudates, and lungs are clear, abdomen non-tender. So what would be the next step in your management of this patient? Anyone have thoughts? Who said that? That was Taylor. All right, yes, it's B, X-ray. Okay, so yes, so this is like a little bit vague, the presentation, but just things to think. You probably would have maybe some more signs, but especially in someone less than 2 years old, they might not tell you that they're having pain with swallowing, and that's why they're not eating, things like that. So just some anatomy of the esophagus. There's a couple constriction points. One is at the cricopharyngeus. That's in adults and peds. Same with the aortic arch as well as the G junction. But then also in peds at the thoracic inlet, there's a constriction as well as at the where the trachea splits into two. So you want to get urgent endoscopy if it's still in the esophagus, so within 24 hours, because you can have erosion of the esophagus. And then, but that's a little bit different if the is larger size object, if it's in the gastric body or if it's sharp. Emergent things for emergent endoscopy would be if there's button batteries or multiple magnets that someone has swallowed. Most likely a child, but could be seen in adults for various reasons as well. So question 2, we have an 82-year-old male presenting with bright red bowel movements since last night, tachycardic, hypotensive. He has bright red blood in the diaper, and after resuscitation, what type of imaging is best going to help you identify the bleed in this patient? Yeah, I don't know who said that first. So I think maybe that was one of the interns. Yeah, so you want to get a CTA. The other types of imaging for a lower GI bleed, you can, oh yeah, those are blue light glasses. I don't use them. Other types of imaging would be an RBC scan. So CTAs are good because you can use it for a brisk bleed. But if it's a slower bleed or an intermittent bleed, you're not going to be able to use the CTA. So that is maybe the times when you would do the red blood cell scan, but it's really not that common. And then multi-detector CT is really highly sensitive and specific, but we don't have that really at a lot of hospitals. This, you can't really see it too well, but it has a lot of the differentials of GI bleed. The most common type of a lower GI bleed is an upper GI bleed. So just remember that if your patient's presenting, you might just consider upper GI being the source. But if it's not, diverticulosis is the most common of a lower GI bleed, followed by some of the other vascular malformations, as well as colon cancer. And then in peds, consider things like Meckel's or intussusception, et cetera. All right, so third question, 32-year-old female, past medical history of, ignore the I meant to delete that. Ignore the penicillin allergy. Presenting with it's not anaphylaxis, it's just a rash. Presenting with right upper quadrant pain, nausea, vomiting. Vital signs are normal. This is her ultrasound. She's tender on the right upper quadrant when you do it. So what antibiotic would be best for this patient? Yeah, Zosyn. So you want to do broad coverage that's going to cover, and then here we're seeing cholecystitis. So ultrasound findings in cholecystitis, the major criteria that you can see are sonographic Murphy's sign, which is actually the most common, as well as gallstones, and most sensitive too for sonographic Murphy's. Other minor criteria you can see is the wall being thicker. So it's 3 millimeters, or a distension of the gallbladder to 4 millimeters, as well as pericholecystic fluid or sludges are the things you can see.
Yeah, I most of the time I'll go with ceftriaxone plus metronidazole, saving Zosyn unless they're really very septic or they had recent surgery and you think they could have pseudomonas.
Yeah.
That's really the main reason to take Zosyn over ceftriaxone. If you're worried about pseudomonas, we only want to use one drug because Zosyn will cover anaerobes, ceftriaxone won't.
Yeah, and in terms of like high risk or healthcare, it's really just about like what resistance is in the area. So if you knew they were colonized with something, or if they got it in a healthcare setting, broadening your coverage farther. And yeah, you're covering just gram negative as well as anaerobes in this, and mostly the Enterobacter family. So on to the fourth question. You have a 42-year-old male, past medical history of alcohol use disorder, being treated for new onset pancreatitis. He's gotten a lot of fluids here in the ER, starts having worsening abdominal distension and pain. On exam, you find his abdomen to be very tense with a fluid wave. What test may be the most useful in aiding this diagnosis? Yeah, bladder pressure. So this is an example of abdominal compartment syndrome. It's the definition is having organ dysfunction as a result of increased intra-abdominal pressure. Normal abdominal pressure is like about 12 millimeters of mercury, and hypertension would be considered in the 12 to 20 range. So if they were showing signs of end organ dysfunction, like kidney dysfunction or other intra-abdominal organ dysfunction, you would consider it in that range. And then for a compartment syndrome, definitely would be something that's worse than like 20. It's pretty rare. We don't see it that commonly in the ER, but there's really high mortality. So it's good to just have in the back of your mind. The treatment you want to try mostly non-operative, try to, depending on what caused it, resuscitate, take off fluid. But if you're not able to, do it with that, you have to obviously go to OR, call your surgeon friends. The most like high risk people for this are just anyone who's going to have a higher pressure in the abdomen. So like an ex-lap post-op patient, or someone with ascites or trauma or something like that. So now switching up the structure, we're going to do a diarrhea rapid fire. It's a lot of the board questions for these ones are just being able to recognize like keywords, and that usually can cue you into what your diagnosis is. So we'll just kind of go one at a time. Does anyone know what like a cruise ship diarrheal illness would be? Yeah. Or recent antibiotics, charcuterie of meat and cheeses. Yeah. So unpasteurized specifically. Conjunctivitis. Yeah. Turtles. Guillain-Barré syndrome. Yeah. And then TTP-HUS. Yeah, that one's more like EHEC. And then tuna. Yeah. I feel like you get a prize for that one. Yeah, so these are just some of the associate. This is another diarrhea rapid fire that Calvin Tan sent out last year. All right, question number 6. We have a 29-year-old female, past medical history of GERD, presenting with severe chest pain that's radiating to her neck and back. She had an endoscopy yesterday, outpatient, and one of your imaging on workup is your chest x-ray. So what would be your best next step in management of this patient? I don't know who said that first, but yeah, D. So this is a case of esophageal perforation. You will also consult surgery, so it's a little bit of a trick question. Sometimes the board's questions do that, where it's like the most immediate thing you want to do. Patients with esophageal perforation can become septic very quickly. And so it's really important, and it's really high mortality. So starting antibiotics on these patients, really broad spectrum. So that actually is kind of hard, honestly, but once you like see the air, you can see it a little bit better. So you have it outlining the esophagus as well as the mediastinum here, and then up in the paratracheal space. So when you go back, you can see like all in here, this air shouldn't be in these spaces. It's a little easier to see on the lateral if you're looking at the skin. And then a lot of times on clinical exam, you can feel it on their chest, like it's like 60% of cases. And then, yeah, you still want to call surgery though. So that's esophageal perforation.
Yeah, you have to be careful how they ask the question, because if it's anything close to definitive or the best step,
Yeah.
that's to get a surgeon, right? For that, that has to go to the OR and clean it out, even if you give antibiotics.
Yeah, that's ultimately going to be what fixes the issue. I think there's a patient in SICU right now with it, actually. And then a lot of the causes, the most common is iatrogenic, so from endoscopy. Other ones you could see would be like Boerhaave from lots of vomiting, or suicide attempts with caustic ingestion or in kids. And then some of the other ones are a bit more rare.
Just like Boerhaave, they're like spontaneous. The thought has changed a little bit. Like not every single patient needs to go to OR. Actually, sometimes the patient that can go home. I would still consult surgery, but I've actually said a couple of things at home.
Iatrogenic has the highest mortality.
No, iatrogenic is not.
No, I know you, I'm just saying, yeah. Iatrogenic has a significantly worse mortality than the other one. We're good at our job.
Well, and the iatrogenic turns out like a giant puncture, right? Like you stuck scope through it with a tiny little minuscule tear that's gonna know itself off in the person.
Yeah, I've seen endoscopy just be watched. I wouldn't send them home. I'd watch them and put them on antibiotics, but I've seen them not being operated on it. But a true Boerhaave's, and they're not common. I've seen only a couple of those in all these years. Those go to the OR because that's an open perf. And often on the X-ray, not only may you see air, but you may actually see fluid in the pleural space.
So moving on to our next question, 42-year-old female, past medical history of PCOS, metabolic syndrome. She's presenting with a gnawing epigastric pain that's radiating to her back. She's having nausea, vomiting, had appendectomy, cholecystectomy, hysterectomy. Her heart rate's 115, but all her other vitals are normal. She has some tenderness in the epigastric region as well. The nurse draws her labs and shows you this, which she thought looked strange. What is your most likely diagnosis for this patient? Yeah. So this is a pancreatitis that was in the setting of hypertriglyceridemia, which can be caused by, genetic causes, autosomal dominant with the disease, as well as secondary forms, diabetes, metabolic syndrome, estrogen therapy, etc.
They can have a normal life.
Yeah.
This is the group that have a normal life based on pancreatitis.
The most common causes are gallstones and alcohol, and hypertriglyceridemia is the third. All these other ones that maybe you would get tested on, but wouldn't really show up honestly on the boards that much, but are good fun facts to know are these more rare causes, especially things like scorpion stings or mumps, but still good to have your little mnemonic, I guess.
This almost exact same, it was in it with a pregnant woman, and they show you the blood, the hyperlipidemia. That was on the in-training exam a few years back. So every once in a while they do something like that.
And then this is just your reminder of the anatomy of the pancreas, as well as the biliary system. So why it's so common to get gallstone pancreatitis. These two ducts come right into each other. So if you get a gallstone there, it'll back up into your pancreatic system as well.
Pancreatitis is pancreatitis, just have a low threshold for HCU involvement or a higher level of high risk.
You're gonna need plasmapheresis, fibrosis. Yeah.
For question 8, we have a 62-year-old female, past medical history of stage 4 pancreatic cancer, presenting with constipation, straining with stool for 3 weeks. She had small bowel movement this morning and is passing flatus. She's doing a home bowel regimen, but it's not helping at all. What medication would be most likely to help this patient? Let's say she already tried B. Yeah, so this is a opioid-induced constipation. So it's one of the ones that you can specifically give medication for. So Movantik or naloxegel is a peripherally acting mu antagonist, so it doesn't affect like the central opioid receptors, so like the opioids will still work. But yeah, so it might be able to provide relief in like someone who's in palliative care and taking lots of opioids. I had a patient the other week who had opioid constipation. We ended up prescribing this. So there's other peripheral agents, methyl naltrexone, or I can't even pronounce this, naldomidine. But yeah, it's just something to have like in the back of your head, I guess, if you have a patient with constipation and they're already trying lots of different meds.
Prescribe this like outpatient or
I prescribed it outpatient. I think it was with Dr. Solway. He was the one who brought it up. Yeah, it might be hard to. Yeah, I think we weren't sure if it was actually going to like go through and that type of thing, but usually you would start with a regular bowel regimen anyways. Even if they are on opioids, you're not going to start with this as first line. But you can add it in addition to all the normal things you would counsel people on, like dietary changes and drinking lots of water, staying hydrated.
that was a board review question. This would have been answered.
I don't know if they would ask us on board review.
Yeah, seen that one.
Yeah, but maybe they would give more detail. Like they'd say that they were on opioids and like what would reverse the effects or something like that.
But in general, when you actually take the board, it's not going to be or experimental treatments. And it's also the board review stuff we do is going to be, you know, a little harder, a little more complex, kind of like that Warhawk question with like multiple right answers. It will be more clear on the board. So board review research do that to make you think, to make you read the explanation because that's not what you're supposed to do.
So question 9, you have a 27-year-old female, past medical history, ulcerative colitis. She hasn't been taking her medications due to losing her insurance. She's coming in with abdominal pain, fever, bloody bowel movements, heart rate 130, little hypotensive, not febrile. She's been taking Tylenol though, and over-the-counter antidiarrheals. Her abdominal x-ray is shown here. What treatments would you provide for this patient? I heard B's. So I was struggling to kind of make the answers for this one in terms of differentiating them, but you want to give corticosteroids. Any other of like the UC agents in a severe colitis flare aren't really going to be helpful. You want to do triple antibiotic therapy or broad spectrum. If you know it's from C. diff, you can treat accordingly. But in this patient, you won't necessarily know. Toxic megacolon, you see like the loss of the haustra here, thinning of the bowel wall, dilation of the colon. You definitely, it's a surgical emergency. So want to consult surgery. And anyone with severe colitis is going to be admitted and started on these broad spectrum antibiotics. So just knowing where did it go? Carly, do you know?
Remember us taking from Fred, which was there,
Just turned off.
saying, being the bad. Not gonna be the one about the food.
Yeah, the biggest thing is to recognize this. It's not common. I've only seen a couple of them. But and in our population, we don't see much ulcerative colitis as you do if you work in Maimonides or Coney Island Hospital. But when you see it, it's very impressive. And sometimes they get big enough they can perf. You may need surgical decompression. I just remember one really bad case I saw that wound up dying, actually first and died. So you just don't want to miss this. And with your antibiotics, you always want to include steroids with this.
Cool. And then last question. You have a 62-year-old past medical history of a gastric ulcer with GI bleeds in the past. They had one episode of coffee ground emesis last night. They're stable in the ER and they've been here for about 10 hours. They're trying to decide if you can dispo them. Do you know of a score that maybe could justify you sending them home? Or if you had wanted to admit them, talking to like the PIC or something? I think I heard it. Yeah, so the Glasgow Blatchford score, you need a score of 0 to use it to have no to be able to say, okay, this is why my patient can go home. It means that they have less than 1% chance of requiring some sort of intervention, whether that's endoscopy, EIR, or other. The criteria on it, I don't know if you can see it here, but it's hemoglobin, BUN, blood pressure, your sex, as well as heart rate, having melena, recent syncope, heart disease, and liver disease. But interestingly, there's not age on there. Like most scores do usually have some sort of age criteria. This one doesn't. Could be helpful if you're talking like PIC and they're wondering why you want to keep the GI bleeder, or there are other scores like a Rockwell score, or you can modify this one to have less criteria, but this is usually the most commonly cited in terms of upper GI scoring system.
Good.
Yeah, and that's it.
Very good.
Thank you to Dr. Gernsheimer, as well as Carly, Milo, and Ari. I don't think I'm missing anyone, right? Okay.